So all of you reached that kind of conclusion where you said, for whatever reason, I want to pursue this unique delivery system, or however you would describe. Can any of you give me kind of like the definition of DPC? If I was reading the textbook of DPC, give me the shortest elevator speech version of what is DPC to somebody who's
You've
not
probably been doing this day in and day out lately.
I have been doing this day in, so full disclosure, I'm not actually doing direct primary care. I'd just like to, and I'm in the process of getting it set up.
Okay.
Probably not till the beginning of the year would I actually be out there having these experiences where I'm learning about the pros and cons directly.
But we can still yap about it.
But we can yap about it. And the motivation is because direct primary care is what it is. It's direct primary care. You're doing primary care. So from my perspective, my job is clear. When I'm working in a sort of a corporate environment, my goals or what's driving me to do things is different than just the primary care. You know, I know that there's a whole system that's trying to operate, and we've got a bunch of different stakeholders in this system, and I want to support the team. And so I may end up supporting things being done a certain way that I think is a terrible idea. It's a waste of my time and a waste of the patient's time. But I'm doing it because I understand it's a bigger process and people will benefit on the whole. So to me, direct primary care is taking care of patients with transparent purpose, and you know, you're doing what you're doing for the reasons that you're doing it. You're not trying to explain away why you're billing something in some racketeering sort of way.
Yeah, you guys have alluded to this a couple of times, but there are different models of DPC, different versions of it, and people always kind of conflate DPC and concierge, and that's always the thing people talk about. But it really is bypassing insurance or third-party billing.
Right.
And for physicians, they understand this. I mean, there is a lucrative part of third-party billing, and then there is a challenging part of third-party billing. Did that play a role in what you guys were doing, or the choices you made?
And partly, and one of the things that I tell people is that with direct primary care, kind of like Quincy said, it's about the patient, but I tell people I contract directly with you, not with the insurance companies. So that's kind of how I separate it in my mind too. And I say it's transparent pricing. You have direct access to me, and you pay me directly, but you have access. You have my cell phone, you have my email, you can see me virtually, you can see me in office. And then the transparency, the access to care, which is huge. But then also, not all DPC offices offer it. Some do. I do in-house blood work. I do in-house prescriptions. So there's also these markedly discounted access to medical care too. And so I think a lot of that kind of plays into my elevator pitch in terms of what direct primary care is and the things that we're able to do and bypass from insurance system too. Even having patients say, you know what, I called few of these different imaging facilities and you can get self-pay for this price. You don't have to go through your insurance and reach your unattainable deductible, you know, so you can bypass it in so many cases.
But you're right that I think there's a lot of confusion out there about what direct primary care is. And even amongst our physician colleagues, I think there's a fair amount of confusion. I'll see people mention DPC on social media posts and things like that, and it does often get kind of lumped with concierge. And there's a lot of overlap. There, so it's for good reason. But I think it's important that I'll say, particularly in York, where we're all, where we're practicing, that the affordability of it is conveyed. So I sometimes will lead with that because it's almost like you're taking concierge level care and access and communication and appointment length times and same and next day visits and all of those things that are kind of the biggest selling points of concierge. And you're making it more affordable for average families because that is really, the price range is pretty vast for DPCs. And a lot of it has to do with what community you're practicing in and what cost of living is like and all of that. And there's strong opinions about what those numbers should look like. But I think on the whole, it's more cost effective for families than concierge care. And so I like to explain that to people because I think that sometimes just knowing that a physician is outside of the system scares patients away because they're like, that's going to be too expensive for me. That's going to be, that's concierge. That's not in my realm, that's not something I'm going to spend extra on. So patients are always very surprised, I think, by what we offer for the prices that we set. and how transparent it all is. Because when you're that open about how much things cost and what you're passing through to the patient, I think people just feel better about it, regardless of what your price is. Like they just know that you're kind of, I mean, most of us don't mark things up much at all, and we kind of just pass those savings right through.
Yeah, I was thinking about we're kind of in open enrollment right now. And
Yeah.
so this has been like on my mind.
business.
So there's a couple of questions about that, but this idea, this emergence of the high deductible healthcare plan, that's getting much more popular now, which I call like the car accident insurance plans, right? I have it because I have to have it, but God forbid I have to use it because, to get to the unattainable deductible on the other side. It's kind of crazy, in terms of the cost that'll go with it. Is that a conversation? And certainly, I will say, before I kind of leave this out there, in my role, I work training residents, and so we're definitely in the insurance land. People are paying, even with insurance, are paying a lot of attention to cost. I mean, this is something, because of the high deductibles and other things, and I find myself having to go a lot, where it's not as transparent to me, so I can't make it as transparent to them. So I completely see where that would come and be a benefit.
It's wild thinking back to when, I was working at a, hospital-based kind of employed physician role. I didn't know what anything cost. I couldn't tell. I just couldn't tell people. I don't know. Do you feel like that? I didn't feel like I knew what anything cost.
I didn't know what it cost. I was shocked when people would say, I got a $400 bill, and that was not uncommon at all.
And you would feel so bad because you weren't.
It was medically necessary.
Right. And you felt like I'm providing the care that I still think is relevant and indicated, but people would come back to you and share the cost, and I would be horrified. But there really isn't a lot of transparency. There's not a lot of training about what things cost or what they actually cost, and then how that gets kind of adjusted. So when I was setting up my practice and getting, making lab arrangements and imaging arrangements, I was simultaneously so excited and a little bit horrified that I didn't know these things. Because you're right, and people are struggling financially, and I think that, every day, I don't know, but like every day, I feel like I have this conversation with people talking about if the practice is right for them, what they can expect cost-wise, what insurance might pair best with DPC is a common question that I do a meet and greet call with every potential patient and family. And that's a common question. Like, we're looking at open enrollment. We're trying to decide what to do, what would pair well with something like direct primary care. But I think the predictability of it is such a huge, important factor. In that way, it's like a gym membership. It's like, here's the flat monthly fee. This is what you can expect. And that, like, reassurance, and then the fact that any additional cost, if we're ordering labs or imaging or whatever, is completely transparent, that just really, I think, is helpful to people when they're navigating, I don't know.
It is. And I think when I do meet and greets too, and I don't offer medical advice during those meet and greets, but sometimes if a patient says, well, I saw that you had a post about, meds at lower cost. Can you tell me what you can get a medicine for? So I'll say, yeah, sure. And it is. When I first got my first shipment of meds, I was sickened. Meds are pennies, and they're upcharged so much. I have one patient, I can't remember the exact numbers, but I want to say it was about $420 that she paid on meds every 3 months. And we got that down to just over $100 every 3 months using my pharmacy. And so the cost and her savings almost pays for the membership itself, which is insane. Or if you have labs 2-3 times a year and it's $400 each time, that's your membership, your savings, because I can order those same labs for generally under $30.
Or one visit to urgent care, or one saved ER visit. Like,
Yes,
sometimes it's hard. People will ask, how do you grow a DPC practice and advertise? And sometimes advertising is hard because it's such an experience, and it's difficult to just put on paper and give people a real feel for it. So I think patient stories and people spreading word of mouth, things like that, is so important. Because it's true. So often it's like, well, we kept someone out of the ER just one time, and that pays for their year because of how expensive things are. So yeah, I think it's pretty incredible. But it is certainly eye-opening, and you do feel a little bit
guilty.
just
You're making me feel
I
bad.
know.
I'm just telling you.
Why haven't I been feeling guilty? I feel guilty.
No, I mean, when you order labs and you're like, hey, what is the right test to order? Or you're ordering imaging, and that is exploding right now in terms of
Right.
people saying, we need to do calcium channel, calcium scores and all kinds of stuff there. And I'm like, well, that is great. Every lecture that I go to those things has zero information about the cost related to it.
Those cardiac calcium scores are not covered by insurance. However, usually $120 to $200.
I was going to say sometimes $99.
Yeah, those are
Yeah.
the best tests ever. It's all the other CAT scans that are the diagnostic.
And why do you think that is? Why do you think this distinction? Because I have my own
Because they're not
assumptions.
covered by insurance.
Because the key is the insurance, right? I mean,
Yes.
there's an upcharge when it comes to that.
Yes.
Yeah.
I remember when I was being recruited to come back, and I was speaking to the head of the medical group, and he was talking about insurance. He was trying to explain it to me, and he explained it in the terms of, how much does it cost to repair your car after it's been in a car accident? And it really is like, well, what kind of insurance do you have? And healthcare was very much operates in that thing, like what insurance do you have, and therefore that will kind of set in a framework around the cost. And I remember relatively soon after that, there was a time where my employer was expanding, and there was a practice in Lancaster County, a hospital in Lancaster County that they were acquiring. Acquiring is a dramatic term, but they were merging or whatever the proper term is. But they had a lot of experience in actually transparent pricing. And they were like, well, why is that? And they said, the plane community. The plane community self-insures. And so for them, they've been negotiating for the cost of procedures forever because that's how they operate. It never changed. And it actually taught the system actually a skill of how to have more transparent pricing, because up until that point, there was no motivation for it. Why would you do that?
Right.
This is a population that needed the care and expected it.
Right.
And so it'll be interesting to see if there are similar kind of levers that occur that allow more transparency and clarity about pricing on procedures or lab work or medications.
That car insurance kind of comparison actually comes up a lot. And it's interesting because one of the things that DPC physicians will say is, you have your car insurance for accidents, but you don't use it to get
You
gas.
never want to use it.
Or an
right.
oil
You
change.
don't get it to get an
or-
oil
yeah.
change. And that's what DPC is. So like for the day-to-day stuff, you don't use your car insurance. You use your car insurance, heaven forbid you get smashed. But you don't use it for these little day-to-day things. You just pay what it costs. And that's kind of what direct primary care is doing in the primary care landscape, is like, here's a predictable, transparent, cost-effective way for the day-to-day. And then, sure, obviously, it's great, to have catastrophic plan or something for in case, something big comes up unexpectedly. But for the day-to-day, is it worth having that sort of opaque surprise bill sort of stress of it all?
Not at all.
And I think patients are starting to say, no, no, it's
completely
not.
not worth it.
One
Right.
of the big things with the high deductible plans, and one thing that came out of the One Big Beautiful Bill, is that starting January 1st, patients will be able to use up to $150 HSA funds per person or $300 per family per month for DPC, which is a huge win for DPC.
That is a very big
It was always a very gray zone, and it was hard because people would call in asking about that, and there wasn't clarity. And we would kind of say, talk to your HR team. We would kind of have to.
Probably not going to get on it.
You want to never want to give bad advice, but it's nice to have that clarity.
Oh, absolutely. I remember early in the discussions of DPC, there was this interesting kind of back and forth that occurred, because sometimes insurance companies in the past, I can't tell you what's new, will approach DPCs and they will say, can we pay for, it's this weird kind of access point. So it's not being a fee for service kind of model, but for them is for our high-risk patients, our high-utilizer patients.
Right.
For situations we're looking for help on because we're losing our shirt on it from a
Right.
business standpoint, there were DPCs who were approached to basically become management of higher-risk populations.
Right.
Is that still happening, or is that one of those vestiges of the early DPC that
I think
disappeared?
you get approached from a lot of unexpected places. I mean, I think most of us work with small businesses in some capacity. Some of our DPC colleagues work with very large businesses, and nearly their whole panel is made up of employer groups. I think that because a lot of employers are starting to recognize the value of having sort of a physician in their pocket, which, and the access is so great. But it's interesting because you do get approached by unlikely suspects, and even like high-ranking people within healthcare systems and things will seek out DPC care, and that always to me is sort of striking because it's just interesting, that you're providing a service that they see the value, they see it, and it resonates, but they're just in a different model.
So you created a model, a DPC model. You didn't create it, but it was created, back.
Started the whole thing.
Exactly, way back.
I remember Dr. Dell mentioning this in like 2000.
Yeah, but Seattle,
2020.
circa 2004.
I have an idea.
I remember. I have an idea. So one of the big selling points for physicians when you're being recruited by a large health system is systemness, integration, access. I can look at the health record and see everything else that has been done within the system. Even amongst the different organizations now, there are mechanisms. So I can see a little bit of what UPMC is doing.
Right.
And they can see a little bit of what I'm doing.
Right.
But you guys are small potatoes.
We're the fringe.
You're the fringe. You're right there. How do you navigate that kind of challenge of you're a part of the medical community? I will say that as a York County Medical Society.
Thank you.
You are part of the community.
That's good.
But that's good for that, and a couple of bucks buys you a cup of coffee. I mean, but how do you navigate that space? That now you have exited kind of the network, as it were. Is there a mechanism or a process to stay engaged in those spaces?
Yeah, so it gets a little spicy sometimes, I'll be honest about that. So when I started, you're right, when you are, say you're out of training and you go into sort of employed, like a hospital system-based practice, there are a lot of benefits there. And when I'm having conversations with colleagues who are considering DPC, again, I'm very transparent about the pros and the cons, because there are a lot of pros to working in those situations. And direct primary care is not right for everybody. And it's not a one-size-fits-all solution, but the connectedness of it all is certainly a benefit. So when you leave, and especially when you're new and starting, it feels different to not have your orders just show up in Epic or whatever system they're using. In my experience, and I know this varies a lot, DPC to DPC and system to system, I did get a little bit of pushback about asking for things like read-only access, where I would just be able to log into their system and see patient charts. That being said, it really functions like any private practice used to. So it's not that different. If I'm sending a referral, they send me their note back. If they don't send me their note back, I call and ask for it. So sometimes there's a little bit of chasing, but it's very, very doable. I think it seems worse than it is.
So, and I think I went in as an employee to a private practice for 7 years, and then we were acquired by a larger health system for 3 years. So, but for those first 7 years, we used a EMR that nobody else had, so it didn't integrate. So I think I was so used to that, and it was fine, so I just survived. I was put into touch, or I reached out and with UPMC, with WellSpan, and I have Epic CareLink, so I can actually put orders in to Epic and I can get all of the reports. So it is fairly easy to integrate that way. The challenging part is that other providers and doctors, I hate providers, but
we're going to say providers. No, we're going to say providers.
Yes. The doctors.
Yes.
Yes, indeed.
So other physicians can't see my notes, right? So that's the big thing. I can see everything, but they can't see my stuff. One of the other issues, and I actually just talked to this patient today, she's in the hospital right now. She gave me permission to talk about her because she is getting her anticoagulants from me. So I'm supplying them. Hematology wrote the prescription, but I'm able to get them for $200 cheaper a month. So she's getting, or for 3 months. She's in there with a blood clot. They said, oh, you are non-compliant. You're not taking your anticoagulation. I am, but my doctor's giving it to me. It doesn't work like that. So the hospitals actually called me to verify because they actually called the pharmacy too. They said, no, she hasn't had her anticoagulants filled since June. And they said, well, let's just send you home and you can continue on what you were on. And I'm so glad she pushed and advocated because she's like, I have been taking this. She failed this anticoagulant, so now she needs another plan. And if they didn't call me, that would have been huge, you know? And so that's the big issue, I think, is others not being able to see my stuff too, not just the other way around.
It really does make you have a strong emphasis on communication. Like when I used to place referrals when I was, hospital group employed, I just placed the order. I wasn't writing this like long narrative with that referral. I just sort of was placing the referral and they could see my note, right? So that kind of, they put 2 and 2 together and that, there was a diagnosis code that went with it. When I'm sending a referral now, there's like an old-fashioned referral letter that I'm writing. Dear Dr. So-and-so, this is Mrs. So-and-so, and here's what we've done so far, and hopefully I'm giving her to you, sort of all teed up and on a platter. Here's what my concern is. Here's my cell phone number if you need anything else, Dr. Dahl. And that's what I get back. And it's really interesting because I get letters back that are like, and even from some of the same docs I used to refer to in the community, where what I would have gotten previously was just the note. Sometimes I'll get a letter or a phone call or a text back. Hey, Dr. Dahl, I saw your patient today. And so there are sometimes extra steps. I agree with that. But it really does feel a little bit more old-fashioned.
And I've been
in
able
that
to
way.
get more doctors' phone numbers. And I think that's great, getting on the phone, connecting with people. Funny aside, in August, a few weeks before I'm starting my brand new practice, my son, who was 5 at the time, almost 6, whatever, he has my phone. We're driving to Ocean City, has my phone, somehow deletes all of my contacts. And my phone had not been updated because the cloud wasn't updated. It was all full.
Oh, no.
So anyone that I put in after a certain year was just gone.
Oh, no.
I was like, are you kidding me? I was like, all of these contacts. So that was kind of tragic, but I am building it back slowly.
That makes me sad. You warmed my heart when you said, I put these letters together
I do?
and I did that.
Nothing
because
if not
back in the
long-winded.
day,
They did that, yeah.
pre-electronic health record, when we used this thing called paper and the charts were gajillion inches thick, that was what we did. Literally with a dictated letter to the
But
specialist
it's so
to explain
meaningful
them.
and it's so helpful to the patient to not expect them to perfectly, especially if it's a complicated case, which hopefully is when we're sending referrals, right? We're relying on our specialist colleagues when there's a real indication there. And it's unfair that we ask patients to be sort of our translator. And if they forget something, the whole appointment becomes useless. And that happens so often. So I recently had a patient who had
Even in the system.
Right, even in the system. Yeah. I had a patient recently who had very vague symptoms, but they were concerning. They were sort of, things that can be quite sinister if, worst case scenario. So we had done this really thorough, diligent workup and then ultimately had some labs come back abnormal that were sort of unexpected and ended up sending her somewhere, but wrote this long letter about the workup. And what I got back was, we're so glad to see she had X, Y, and Z. We agree that with ruling out all of these things, here's where we are. And it was the most collaborative, supportive, and I didn't always used to feel like that,
You're getting to something that's kind of important to me as well, is the medical community aspect piece.
Yes.
And I'm struggling with this from a medical society standpoint. I'm struggling with a little bit from a physician standpoint. This is my tribe kind of thing. And we used to have these things called grand rounds, and people showed up, and you would develop these relationships over time, and you would curbside consult them about X, Y, Z thing, and that kind of familiarity with each other, I think, led to really outstanding collegial workup. Cooperation, you were less likely to shoot your mouth off. If somebody did something unexpected, you would actually pause and go like, maybe they
Assume
did
good
something
intent,
that
right.
I was missing and they're actually fixing something. And that provided better care for that patient.
Right.
That ultimately was the goal of all those conversations in those spaces. And we've struggled with how we've lost this. COVID, I think, put a fork in it a little bit, but it was already happening long before this. The electronic health record really pushed us on this into this much more time constraint, compressed space. And what is the answer to this?
Right.
And I don't think there's one answer to it, but I am heartened by a little bit of the conversation here because this is part of caring for patients directly to kind of,
In
twist it the
family
other
medicine, you're the quarterback.
way. Yeah.
And like, do you feel like the quarterback when you don't know anybody that they're seeing and you don't know your patients deeply and you don't know their preferences and you don't know, like that's such the core of what we do. And having patients say, can you please recommend, I had one 20 minutes before I got here, can you please recommend an ENT who does this specific thing? And it's like, yes, I can. I was chatting with him last, and it's just so nice to be able to really have that level of connection with patients and also with your colleagues where you're like, I know they're in good hands. Like, I know that they're going to see Dr. So-and-so and they're
That
going to
makes
do
such
the right
a difference in terms of the buy-in from the patient.
Yes.
I mean, it's a completely cheesy thing to say, but man, we all know it. When you
important.
say, I'm sending you to this because I know this person, I am referring you to that person.
Right.
They are the best in the area for this individual.
Right, and it's a bad
Send my
feeling when
mother
you don't
there.
know.
Let's
Right,
send-
it's a bad feeling when you're like, I don't know any of these people. And that's hard. It's hard with turnover and how fast things are changing and people are moving practices.
I think the
tricky.
change is a big part because it's the reason I want to do DPC now is because I've noticed this change over the past 10 or 15 years. And I used to think, let's join a system because of the value of the systemness. And
Right.
what I think I've noticed is it's counterproductive. What happens is you build this system and then everybody's acting like it's a system and you're not acting like it's individual people or individual doctors. You're just saying, I'm referring to whatever specialty. And it's not a doctor. It's not even an office.
when
It's
you
just you're putting in an
request
order.
that,
Right.
they-
Yeah, they do not. Yeah.
Yeah, and so it goes back to the transparency and accountability thing. Like if you're just part of a system, well, you're not really responsible for the patient because you've got 2,000 patients.
Yeah,
And
that
you can't really
ownership.
pay that close attention. Come on.
That ownership is so important.
Yeah, the system is taking care of the patient.
You have
It
to
takes
be
the
that
individual out of
advocate.
it.
Yeah.
Yeah, I mean, that's still the thing that, the young learners drive me a little nutty with that, right? I mean, because there is a part of me that it's just like, this is personal. When I'm taking care of a patient, it is personal. I'm spending my time doing this, okay, my time, but it's deeper than my time when I'm working with a patient. And I want that to be communicated to that next generation. I want them to understand this is a privilege that we get to do this work. And it feels cheapened somewhat when you're placing an order to a non-specific whatever, and you don't know for sure what is on the other side of that I'm referring to.
And that weight is palpable in direct primary care, I will say. So many of us go into DPC and we're solo, which is unique because we're used to having colleagues to bounce things off of. So that kind of turns up the heat a little bit. But also the weight, the heaviness of that a patient is coming to you directly. They're seeking you out. They're choosing your practice. Your responsibility to them to take care of them and look out for them and, be mindful and be thorough. That weight is palpable. It can be hard. Like when you have a case that, like this woman that we were working up and it was very vague. And I don't think it was vague like we're not doing the right things. It just was that kind of case. And cases like that will weigh on you and keep you up at night in a different way because this lady, like it's just such a deeper level of connection, I think, that it can be heavy, but it also is kind of the beauty of what we do. And I think that investment from both patient and physician is so, I don't know, is it like you've been doing it, like it's a
absolutely.
recent change, so
It's
do
very
you feel that
humbling.
differently? Yeah.
It's very, yeah.
So what's new is old again, or what's old is new again, depending on how you look at
An
it.
old
right?
woman.
Yeah.
No, but it, no, but
Old
it,
soul.
no, but it is that thing. I mean, medicine at its best,
Yeah.
we all carried that weight.
Right.
I mean, that's when we were practicing the right kind of medicine. I will argue.
Right.
That was.
That's
really-
exactly right. That's exactly, and it's like we've tried to engineer it out of the process,
Right.
and you can't take that out of the process. That's what does it.
'Cause the
That personal
patient
connection is what makes it work.
left lingering.
Yeah.
Like at the end of the day, if you're not carrying that weight and thinking on their case and guiding them through it, there's just a patient floundering, looking for care.
And even, referring people. I have very specific people I like for certain things. And
Oh,
I
yeah.
said, I want you to see XYZ for this problem. I'll put it in the referral. And then it goes to the central referral department. And then it just
get me
gets
started.
taken care of, regardless of whose name is there. And then I have a local optometrist that I really like. And he would always get people in for urgent needs. And he said, I haven't seen anyone from your office recently. I said, that's odd because I'll say I want it. It was frowned upon to pick up the phone and you make that call. We had to trust the process. And we had to leave
trust no one.
everything. Yeah, exactly. And I'll admit, and my prior staff will say I'm a micromanager because
Yeah.
I don't trust anyone and I don't trust the process. And if I could, I would do everything. And now it's a lot more responsibility, it's a lot more weight, but I know the patient is getting that right care and the referrals to the right people.
You're talking about the weight and the responsibility that you're a micromanager, but we started this conversation saying, I wouldn't trade it. I feel like I have my life back, that it's highly satisfying. How do you reconcile those two things?
It's hard. I mean, it's hard. I think that, and you hear a lot of thoughts on panel size in direct primary care. You hear critiques of it because of physician shortages that were worsening the physician kind of access to care. So there's lots of different thoughts on
My
that.
patient panel would be 0 rather
Right,
than
and that's always kind of my argument.
Yeah,
It's like, well,
yeah.
people are leaving the field left and right. We're dropping like flies. People are not going into primary care. We had so many unmatched residency spots, So, I think you could probably get into a pretty good argument about, is it better to just keep scaling back on your hours to make it survivable? Or is it better to keep a smaller panel and sort of invest in them wholeheartedly? Anyway, there's argument there, but DPC is not sort of an easy way out. And sometimes you will hear it touted as that. If people are feeling burnt out in the system, if they're feeling like, I have to get off this treadmill, the workload is too much, I'm charting late at night, you will see people suggest direct primary care to kind of claim their life and get their life back. Once again, I'm always so honest and balanced about it. There are pros and cons because in some ways it's heavier because you can't clock out. I'm having a whole baby, and people are like, well, who's gonna, me? Me, like, I will be managing, So there's not this built-in coverage, there's not this just ability to kind of put it down. And I'm not downplaying, I don't think most of us, even when we're employed, like, we're not taking it that casually, but I'm just saying it's a different level of individual responsibility when you have a practice, especially a solo practice. But I think when the work feels so worthwhile and you feel so connected to your patients, it's just different. And I think that the work of medicine isn't what most of us mind. It's the nonsense. It's like,
being devalued. It's being
right. It's the unnecessary work, and it's the like treadmill. Like, I have to see 20 to 30 people. I'll spend all day noodling on tough cases and working with people and sitting there interacting with my patients and not feel the same fatigue that I felt spending the same exact hours, but going door to door to door to door to door.
Yeah,
So it's just different.
I love working. I absolutely hate wasting my time, though.
Right.
And that's what it is.
Right.
It's like, oh my God, I could have taken care of everything you need taken care of, but I can't do it because I
Right.
don't have, this is not set up the way it needs to be
You
set
have to
up.
trust the process.
Right.
It doesn't work.
Right. And so I feel bad about myself. I feel bad for the patient. We did a crappy job, and it cost too much money. So it's like,
It's really that
it doesn't make
moral
any sense to do
injury,
it that way. And I
it's
can't do stuff
really
that doesn't
hard.
make sense over and over again
Yeah.
because it starts to drive you crazy.
Yeah. So getting to let go of some of that stuff, even though, like, I might work more hours now than I worked when I was employed. That's not a might. I work for sure a lot more hours.
I
now.
heard about your hours.
I-
We're setting this up. a little.
Your girl is there at the
Yeah,
office, but it's different. It's my office, and it's lovely, and it's
You have
it's
control.
good, and I have control. And if somebody, I have these situations pop up where somebody's catching a flight, and oh my goodness, they have something and they need to come in, and I meet them at 6 o'clock in the morning in the office. And is that something I would never have had to do before, and I wasn't really, on the hook for before? Yep, but like, great. It's just such a nice thing. That's what family doctors do. So it's so meaningful that you're like, okay, like, fine,
Yeah, I used to laugh about it when I was
wash.
in trading. Like, Doc Smith, he was the best doc ever. Like, they'd be like, family docs, they don't know what they're doing. Doc Smith really knew what they were doing. Like the generalist who did no residency training.
Yes.
Right? But what made a difference in people's relationship with Doc Smith was Doc Smith was there.
Was there.
Was present and was engaged with them. And there
Yep.
was nothing that kind of there. So I always used to laugh at the story about that. I'd be like, there's an irony in what you're saying, and I don't want to point it out to you because
Right.
I'm a
better
smart
you
aleck
don't
doing
know.
it. But the joke's on me in a sense because Doc Smith figured out something that a
Yeah.
lot of us are rediscovering now a little
Right.
bit, which is the primacy of that relationship and carrying that weight, but also that responsibility, but also the joy that comes with it.
And if you show up for patients like that, again, for what most of us are charging, like it just becomes a no-brainer. Like when I was building my practice, I was thinking very much of other people in my position. Like I was a mom with young babies, and I wanted to build a practice that parents with young babies would really feel connected to and would feel like was valuable for them. And I'll tell you, when it's 2:00 in the morning and a patient, texts me a completely black video and it's the sound of their child coughing, and you know that they have croup, and you just handle it, and you say, "Come into my office, and we'll just give you the when you just take care of it." That one interaction carries that patient for a really long time because it's not that people are asking for so much, but like, look at what they're up against, like the alternative.
And they want people to show up. They want people to
Yes.
care. And, I, with just starting out, and I don't know how prepared you were, but I was worried, I don't have all of this. I don't have this equipment yet. I apologize to patients, the labs weren't set up yet because it took forever and a day. But every single person was like, that's fine. I just want you. Like
Right.
they want to be heard. They want somebody to be their like partner in health. They want somebody to advocate for them. So I think just showing up is
Yep.
half the battle in whatever capacity.
Yep.
And I think that's huge.